Welcome, everyone connected on the call. I hope I'm loud and clear. Someone may just confirm.
Yeah, very loud and clear, sir. Thank you.
All right, thank you very much. Welcome to today's MOH HIV TB Echo session. Today's topic is recency testing data utilization. And we have our team, subject matter experts, and our presenter for today. But even before I introduce them, I'm going to ask that we may please remember the echo etiquette and mute our microphones. And then I'm going to ask that when you want to speak, please use the key to raise your hand. And I'm also going to ask those who are using video that just ensure that there are no distractions behind you. If you perceive that there'll be distractions behind you, I'm going to ask that you actually maybe disable your video temporarily unless you have to use it. Thank you. So our presenter for today's topic is Madam Judith Mzyece with the Ministry of Health, a TB and HIV technical expert. We also have from the Ministry of Health, consultant in infectious diseases and also internal medicine, Dr. Sombo Fwoloshi. I don't know if she's already on the call, but if she isn't, if she is, Dr. Fwoloshi, you may just acknowledge. However, if she isn't, she will join us. We also have our cooperating partners, experts, doctors from CIDAS, Dr. Mwenya Mubanga, and also Dr. Natalie Vlahakis. We also have from MOH, from Levi Mwanawasa, Madam Fales Zulu, who is also from our laboratory at Levi Mwanawasa Teaching University Hospital. Today, we have set out objectives, which include define recency testing and the recent infection testing algorithm, otherwise known as RITA. We are supposed to describe the third test in the HIV testing algorithm. We are supposed to understand use of recency data to inform prevention intervention programming. Without further ado, I'm going to ask that Madam Judith Mzyece may take the floor. Thank you.
Thank you very much, Doc, and good afternoon to everybody on the platform. As not to lose my network, I will disable my video so that I can reserve some bandwidth, because I'm not in the office, I'm somewhere out in the outskirts. Okay. So I'm very glad to be here today, this afternoon, to share with everybody or to remind each other on what recency is all about. And like I've mentioned, that my network is quite unstable, so I hope the ECHO team will be able to do the slides.
All right, I think we have Mr. Chatonda Mvula on the IT and our coordinator. I think Madam Mercy Akufuna is also logged in. I'm going to ask. Thank you.
Thank you very much. We can now go straight to our objectives. So like Dr. Mshanga mentioned, these are our 3 objectives. And we hope that by the end of this session, we would have all understood what recency is, even RITA itself, as well as the use of recency in the prevention and intervention programming. I hope that this presentation will also respond or answer some of the questions that the people in the facilities, the people that are implementing, do have. So we will start with a definition, so we can move to the next slide. We want to first define what the recent HIV infection is. And it is defined as a newly or recently acquired HIV infection. And it has to be detected by a given laboratory method or incidence assay. So it involves testing here for you to qualify something to be a recent HIV infection. So this HIV testing actually involves the use of the recent infection testing algorithm, which is the RITA, which is a combination of the test itself, the rapid test for recent infection, with HIV viral load, the same viral load that we do for HIV, to identify the true HIV recent patients. So this recency testing is very important because it helps in identifying areas of high transmission, also the affected populations, and helps the healthcare providers to focus on intervention efforts. So when we come to, when we look at the recent HIV infections, a few things do come up, and some of these are the high viral load. You find we look out for the clients with the high viral load, and these clients, they also have, they present with a weak immune response. Because these people, maybe they don't know that they are positive, you might find that they continue with their high risk behavior, and they have a higher probability of transmitting further, of ongoing transmission to others, because they do not know. And with the recent recency or recent HIV infection testing, it gives us an opportunity to interrupt this transmission. So once we know where these recent infections are, we're putting interventions. That is an opportunity for us to actually interrupt this transmission. So you will see, when you think of it, it might offer, or you might think that it offers an opportunity for contact tracing, as well as increasing the yield of HIV testing by partner testing. So for the last two bullets, which is the contact tracing and HIV positive persons, that is the partner testing. This is not being done for in our program, because with recency, we do not do any contact tracing. Why we do not do this is because the facility will never get to know who these people are. When they send the samples for recency testing at the hub, at the PCR lab, they will never get back that recent result, but they will get back the viral load. So, and even when the results are shared, they come in as aggregated. So it is not possible for us to do the contact tracing as well as the partner testing. So how can you do partner testing when you do not know who these individuals are? So that is what I wanted to highlight, because I know we do get a lot of questions on why we cannot do contact tracing. And that's just some of the critical components of recency. Is number one, the location of the testing. So this, the testing is done, the HIV testing is being done in the facility itself. Then those which are HIV positive are the ones that we send now to the hubs, to the PCR hubs, where the RITA testing is done. So here you will see, because of the way, the model that we have adopted as Zambia, in the way we do our testing, where the HIV test is done at another place and the recency test is done in a different place, we are unable to do the case-based surveillance, because the hubs or the PCR labs, when they test, what they do have are aggregates and not cases. So these components of the case-based surveillance for us in Zambia is not possible because of our model of testing. Then we also have the issue of return of results. So these recency results, they are just used for surveillance only, and we do not send them back to the patients or to the clients for them to make a decision, because an HIV positive, whether it's recent or long-term, it's still a positive, and that person or the patient qualifies to be put on treatment. So there isn't really any change that the recency result is going to make on the treatment of the patient. And in terms of the near real-time data capture analysis, so for us, we might say it's a near real-time. It's not real-time because we wait for 6 months before we do an analysis to look at the recency data for the past 6 months, what's the pattern like, and to make decisions. So this is also one of the issues that we have actually modified as a country, and this is where we are going, that it's not real time. The other component is that the data that we get from the recency program is actually used for program improvement and public health response. And I'm sure for our provinces where we have been implementing recency, most of you must have seen, or you must have been involved in a public health response where you now use or you make decisions based on the data that you have, that is the recency data that has been given, and you now make or prepare interventions to address those areas where you are getting the most of the recent infections. And the other critical component is the monthly QC and the periodic proficiency testing program. I know this is mainly for our lab people. This is key because we need, for us to really be confident in the data or in the estimates, in the numbers that we are getting, we need to have quality data. And the only way we can have quality is if we do participate in the QC and also in the proficiency testing. We do not want to have people who may be failing to distinguish the color of the bands or failing to interpret actually the results. So that is why we periodically actually have the proficiency testing for the recency as well. So in terms of coverage as a country, this is where we are. And what we have is actually, we are in 4 provinces. And in these same 4 provinces that we are in, we are not in all the districts. So we are in, in terms of facilities, in 723 facilities. And these are all the ART activated sites in the country. The map of Zambia there is showing you in which districts we are. That is the blue on the map. So out of these, we have actually, out of the 723, we have had 561 sites that have been reporting for recency. And so the total number of districts that we are in is actually 27. These are the districts that are participating in the recency. And there are actually plans to expand, and that is to all the 10 provinces, and have that will be a full representation of the whole country. So we will add the other 4 provinces as we go. The plans are actually underway. So now that we have spoken about the coverage and also what recency is about, I'll hand over to you, Dr. Mshanga, to take us through the first part of the course.
All right. Thank you very much, Madam Judy. Yes, thank you, very elaborate. I think I'll go through the first poll question following from what we have heard, and it says, what is the value of recent HIV infection testing? Option A is high probability of ongoing transmission. Option B is opportunity for interruption of transmission. C, contact tracing. D, likely increase yield of HIV testing by partner testing. And then option E says B and C are correct. Kindly note, just choose one option, A, B, C, D, or E. The poll has been launched. I'm going to encourage people to participate. We only have 25% of connections polling. I'm going to ask, this poll is anonymous. We will not know who answered what, so kindly feel free. There's someone, Miriam said she can't see the poll. Miriam, depending on the device you are using, there is a bar at the bottom which says polls/quizzes. If you can't see the poll, kindly click that, then you will see the active poll that is showing, and then you can select and put your answer. Kindly avoid using your answers in the chat box. Just use the poll. It's anonymous and it will guide our expert, Madam Mzyece, to see what to focus on. So far, we have 55% of connections. Kindly poll. I'm going to give it 30 seconds more. Okay. Can we touch 60%? We have 57% polling. Okay. Okay, I think 60% has polled. I'm going to ask IT if they may just end the poll. Thank you. Madam Judy, a very interesting answers, responses, kind of a split between option A and E, as you can see. So, Madam Judy, maybe we can proceed from here.
Yes.
Okay, you are polling. Okay, we proceed from here, and then yes, thank you.
Okay, thank you very much, Doc, and indeed quite interesting answers that people have given. So, like I had earlier mentioned, that I'll start with B and C. So B and C, I know it was tricky for people. So I mentioned that for us in Zambia, we do not use it for contact tracing because you do not get back the individual results. So it has then, that means that it has no value to contact tracing, that is the HIV recent infection testing. And so for A, high probability of ongoing transmission, this is, yes, if we do not test for recent HIV infection, we are going to have ongoing transmission. But when we test, we actually, that is an opportunity to interrupt that transmission, because we will find these cases, these are isolated cases, and then start them on treatment. So the answer here is B, it offers us an opportunity for interruption of transmission. Then D, the likely increase of yield of HIV testing by partner testing. I did mention here that this cannot happen because you do not get back these results. So C and D cannot happen because the facility does not get back the recency results for their patients. So if you do not have these results, how then are you going to know that this is the person that you are going to do the contact tracing, or you do the partner testing for the individual? So we can, okay, on my side.
All right. Thank you, IT. We may remove the poll.
Okay, they've moved to the second one.
Okay. So poll question number 2 simply says, recency testing is part of the national HIV testing algorithm. It's just a simple yes or no. Thank you. We may poll. Answers are coming in. This is much faster. It's a simple yes or no. Hopefully we'll hit 80%. Kindly use the poll, not the chat box. We can understand. Okay, we have 62%. We may end the poll, IT, and let Madam Judy take it on. Thank you. Madam Mzyece.
Awesome. Thank you very much. And so this is quite interesting. We have 31% saying no and 69% saying yes. So Dr. Mshanga, this shows that there is really there was need for us to really come and share on recency testing, because recency testing is indeed part of our national HIV testing algorithm. And I will indeed show it in our slides later on, but it is. So the answer here is A, which is yes.
Thank you. IT, we may end that. And Madam Mzyece, please proceed. And thank you very much for those eye openers. Let's follow. Thank you.
Now that we know that the recency testing is part of our national HIV testing algorithm, we will now get straight into knowing more about this SEM test itself. So the recency, the recent test, which is the Asante that we use, this the visual just shows you how the test kit itself looks like. You have your strip and the loop that you use to put the sample. And then below there, it just shows the interpretation of the results. So this kit is actually used just for HIV-1 infections. It does not pick HIV-2. Then it's very useful when it comes to evaluating the impact of the HIV intervention, the programs that we've been putting in on new infections. Are they working or are they effective? And so if you are getting we are still getting more recent infections, then it means our interventions are not working. But once you start getting fewer number of recent infections, that shows that your interventions are actually working. And with this kit, you are able to identify the populations that are at risk. And once you know that population, you'll be able to even come up with interventions that are specific to that population that will help even address their issues, because we all know that different groups require different interventions. We don't have a one size fits all kind of approach, but we do have targeted interventions or based on the type of population that is actually affected. Then with this kit, we are able to detect the hotspots that we have in our districts. These are the pockets where we are going to get a number of the recent infections, and then we are able to plan for the prevention program. So with this kit, when you just have one bar which is on the control, then it means it's negative for recency, and when you have two, that means that you have it's a recent infection, and the long-term infection actually has all the three bars there. So that is what those two readings below there is actually showing. So the beauty with the Asante test kit is that it uses the antibody avidity. That's what the principle behind it. It uses the antibody-like avidity. So what do we mean when we speak of the antibody avidity? This is just the binding strength of the antibody. That is what we are actually referring to. And this binding strength of antibody is actually a functional property of maturing antibodies. And with this avidity, so it increases over time after seroconversion, and it's also a good surrogate marker of time since infection. So with our recent, with our Asante, so the period that it is able to peak is less than 1 year. So that is why we are referring to it as a surrogate marker of time since infection. So if somebody has a recent infection, then they must have gotten infected within the 12 months. But after that, then it is distinguished or described as a long-term infection. And it can be used to detect and distinguish the recently infected persons from the long-term infections, like you saw on the strips, that the examples that I did show, that the same strip will give you either if it's a recent infection or it is actually a long-term infection. So on the next slide, we're just trying to show you the principle, and this is the limiting antigen antibody avidity. So what basically happens here is that when you have the excess antigen, you have both low avidity and high avidity antibodies that are going to actually bind to your membrane on the test strip. And then the limiting, which will now result when the limiting antigen now comes into play, and it will result in only having the high avidity antibodies that will bind, which is the long-term infections, or the low avidity antibodies will not bind, which means that it is actually a recent infection. So this is just the principle behind the Asante test kit, which is our recency test kit that we do use. So here we are just showing the same, this is a schematic representation. So the C is the control line, and this is where the human antibody IgG will actually bind, and it indicates if the test result is valid. So just like any rapid test kit, the control line has to be valid at all times. Then for the second one, which is the V, it's the positive verification line. This is actually, it verifies the presence of the HIV-1 antibody. This is the one for our recent infection. Then the LT, which is the long-term line, is actually the long-term infection, and it indicates if HIV-1 positive diagnosis is long-term infection. So with this one, It can only capture the HIV-1 antibody with strong avidity, but not low avidity antibody. So like I explained that with time, as time goes on, as time passes, then you have actually the binding strength of the antibody actually increasing. So this is what happens, or this is the explanation on the long-term line. So now we can get to our national algorithm, which is what we use in our facilities. And this is just proof that the recency infection or recency testing is part of our national HIV testing algorithm. So from there, you can see if you have your HTS client, you do the rapid test, which is usually determined in our facilities. And when it is reactive, we do the SD bioline. And when it is positive, we now send it for recent infection testing. This is where now the Asante kit comes in as in the third test. So this is speaking to our objective number 2, where we are looking at the third test, which is the Asante. So once this is the test is done, it will distinguish if it is recent or long-term, and those long-term, they are you end there. And if it has tested recent, then you do the viral load testing for confirmation that it is really a recent test. And if the viral load is unsuppressed, this is above 1,000 copies, then you are actually going to report as recent. So this is our national algorithm. So this is just a simpler form or the cascade, which just simplifies our testing algorithm, that the clients who visit us for HIV testing, if they test negative, they fall off. And those that test positive, we continue. This is on our the algorithm. And those positives, we now test on the RT-RI. And if it's still positive and they have consented, excuse me. And I must emphasize here that this is for the age group 15 and above. We only test for the age group 15 and above. So if HIV positive but not eligible, or they, let's say like maybe they don't qualify because of the age, or they do not consent, then they will fall off. But if everything is in place, they have consented, then that is when we go for the RT-RI testing. And once it picks that it is recent, if it is long-term infection, it falls off. But if it is recent, then we do our viral load and we classify accordingly. So if viral load will tell us that actually this patient is unsuppressed, then we classify them as recent, and those that are not, those are the long-term infections. So this is our simple cascade, and this is also how we report or we account for all the patients in our facilities once when we are reporting. So you start with those that were positive from the HIV testing. First, you start with the number of patients or clients you had for HIV, who came in for HIV testing. Of those, how many were positive? So this is a cascade of how we actually account for our patients. So this says, I hope I've made it very simple. I've made
So February, I'm results with the which February.
So this is where I end on in terms of the algorithm, and over to you, Dr. Mshanga.
All right. Thank you very much. Very brilliant. And I hope, Madam Judith, there are some concerns in the chat box. Maybe as we are going through, you may also just take note. The poll question number 3 simply says, let me just mute Mr. Kalima. All right. Poll question number 3, why use the rapid test for recent infection? That's the poll question. A, to identify gaps and tailored solutions. B, to effectively address harder to reach subpopulations. And C, to be able to count versus estimate new infections accurately over time in real time. And then D, all of the above. The poll has been launched. The poll has been launched. Yes, kindly poll, reminder that this poll is anonymous. Yes, we have only 35%. May we please poll? Okay.
Me, I can't see the poll.
Sorry?
I have no option to answer the question.
You have no option to answer the question. Maybe just check on your side if others are answering, so it should be something on your end. Kindly click pause quizzes and ensure that you have selected the currently ongoing poll number 3. If you choose anything earlier, you might not be able to choose. The poll is still open, it hasn't yet been closed, and just under 60% have polled. Kindly just recheck. Thank you. Okay. In the interest of time, maybe we allow for okay. IT, kindly take note. There are apparently some people who are, I don't think it's IT, because 60% have polled, and I think those who are failing to poll, kindly just check. It should be something on your end. Okay, it's not something to ask IT, I think. IT, we may end the poll and kindly share the results. And then our presenter, Madam Mzyece, here you have 2 groups of people that the poll is split, almost half and half between C and D. How do you look at that?
Thank you very much. So quite interesting, and for sure there is, we did add a word that people did not pay attention to, the real time. So a lot of people, yes, you are able, recency is good. It's why you're going to use it, you want to be able to count versus the estimate of new infections. And over time, in real time. Remember, I did mention that for us in Zambia, we do not have the real time factor, because we take 6 months to actually analyze this data. We do it in cohorts of 6 months. So 6 months cannot be real time. So that was the catch there. It's the word real time. But for sure, it is good because it will help you to identify the gaps and have tailored solutions to actually to the challenges or to the groups that you are going to have. So that is our answer there. Thank you very much, IT. We can move.
All right, poll question number 4. Thank you very much. So I think just a reminder to our network. I know that some of us might have already read the recency guidelines from whatever sources, and we may be using our general knowledge of what we have read to answer these poll questions, but we need to understand how our country is implementing these things. And if we just answer from what we know is supposed to be, or what is in other places, or in maybe ideal places, we might just get to be missing it. So let's also think about the real life scenario, as in what is actually pertaining on the ground in our situation with the Ministry of Health Zambia. Poll question number 4. The recency assay principle is based on a novel approach of using limiting amount of antigen, thereby limiting the ability of low avidity antibodies, usually from recent infection, to bind, while allowing high avidity antibodies present during long-term infection. It's a true or false question. The poll has been launched. We may start polling. Once again, it's anonymous. Just pick one. Okay, kindly poll. We have under 50% polling. We're at 50. IT team, maybe let's just end the poll and have our presenter have a look. Madam
Wow.
Judith.
Thank you. This is quite impressive, and for sure the answer is true. Even the schematic diagram did show us the principle behind the limiting antigen factor. So this is really, really good. It is true. So we will now, since we have spent some time discussing how Zambia is implementing recency, which is different from what literature says. We've highlighted the things which are different from what others are doing. And also we have reminded ourselves or each other of what recency is all about. So now allow me to now give you some, to just share with you some data. This is our very own data from Zambia, just so that you can appreciate what is coming out from our provinces. So like I mentioned earlier, that we do actually wait for 6 months. The analysis is done after 6 months. So that is over 6 months. And the one for 2024 is not yet ready. We could have shared that, but we do have for the period up to September 2023. So we are here, what we are just sharing with you is the contribution of the recent infections from our provinces. And these are the 6 provinces where we are implementing recency, that is Lusaka, Copperbelt, Southern, Central, Eastern, and Western. So with Eastern and Western, the numbers look low because we are only implementing recency in 1 district each, that is Chipata and Mongu respectively. But if you look at the contribution, that is the percent, you will see that they are not any different from provinces like Central or Southern Province, which has a number of districts where we are actually implementing recency. So we have Lusaka leading, and that if we go by percentage, which is followed by that's Eastern Province, and then Copperbelt and the Southern. So this is just the percent of our confirmed recent infections. So we can move on. So I'm just sharing this so that we can actually appreciate the works or the numbers or the information that is coming from our provinces. So here we are looking at the confirmed recent by age and sex. And you will see the pink is female and the blue is male. So you will see that in all the age bands, we have more females testing positive that are confirmed recent than males, apart from the age band 30 to 34, where we have the same number. So we have more of the recent infection in our females as opposed to our males. I hope the platform, they do understand, or they have an idea of the dynamics of health-seeking behavior that our women have, and also the kind of risks that especially the age bands that we're looking at, 15, 19, 20 to 24. These are our vulnerable young girls or young women that are exposed to quite or that engage into risky sexual behaviors. So that could be, those could be some of the reasons why we are seeing more of our females having the recent infections in that in those age groups. So for our national coverage, this is for January 2022 to January 2024, and this is how we are looking. This is where we are. Yeah, I don't know. I'm trying to. Apologies. I'm trying to block the chat because it keeps on coming to the screen. Okay, so in terms of the coverage, that's our national coverage. This is how we are performing. And for as of January 2024, we actually, in terms of viral load coverage, we had dropped from the 90s. We are now at 84, and even the coverage for for the recent infections, we are very low at 63%. So this is how our performance, and I'm sure all of us know that our target is actually to be is actually 90% for the recency testing, and viral load. Yeah, our target is actually 95, or target coverage is 95%. So this just shows that in both areas, that's a viral load coverage as well as the recency itself, there is still a lot of work that needs to be done. We need to tighten the loose tabs that are leaking, the patients that we are losing, or in any of at any point of the cascade that I had shared, because once you lose any client or patient in the cascade, that is what is going to result in the low coverage. So this is actually what we wanted you to appreciate, And I do know that some of the issues, like in the month of June 2023, we were affected with testing reagents, and our equipments were down. So that is in terms of the viral load. But yeah, we are trying, and our goal is that we should ensure that our coverage for both the Recency and viral load itself are always above 90%. So this is our performance. And so from this data, we did use it to identify the areas that had high transmission, the areas where we were getting more of the recent infections. And this data is what we use to come up with the hotspot analysis. So we did do a hotspot analysis, and due to the limited time that we have this afternoon, I did actually leave out the maps. We would have, it would have been very nice if you saw the maps and appreciated what was being done. So IT, we can move to the data flow so that I explain the next slide. Okay, thank you. So this is the data flow for the hotspot analysis that was done for the period April 2023 to September 2023, where we had a total of 726 activated sites and 569 were reporting. So out of the total tests done, that is 743,743, this is for the HIV testing. We had 31,000 that were eligible, and of these 31,220, we then had Recency done. That's the Recency test done, and of the Recency test was done on the 22,859, and of these 19,137 were actually classified as long-term infections. So the remainder, which is 2,976, are the ones that we now had to do the viral load. And from the viral load, we actually got 1,700 falling off as that they were long-term infections. And we had a number, that is 61, who were excluded for missing some coordinates. And we, in the end, in this cohort, so we had 1,127, which were confirmed as recent infections in that period. So if you have noticed on the long term, the first long term, the 19,000, that is an issue of retesters, people coming back to test. And so there is this issue of people coming back to retest, and that they would not disclose that they actually already know their status. It is a challenge, because then it results in reclassification. Sometimes you will just reclassify, you will, without knowing, you are going to put this patient as a new patient. So next slide, IT. So the challenges that come with the retesters on ART is that there's a high reclassification, which suggests that there's a lot of non-disclosure prior to diagnosis, and ART use is still common in our routine HIV testing settings. So this actually impedes the efforts that we are trying to identify the new infection versus the long-term infection. So the challenge of retesters is it's a big issue. I know it's a health for all, but when you look at it in terms of resource, it is indeed all those test kits that went to waste because the clients or the patients are not disclosing their status. Then the recency surveillance through the utilization of RITA, it can quantify and describe the retesters like I showed you on the previous slide, and it can help ARD to improve efficiency in terms of the testing strategies that we need to do. So we really need to improve our screening tools to ensure that we filter out, we get the correct information to avoid retesting. These are already known positive. So the retesters do affect, it has an impact on ART. So on this, the next slide is just a map. This is the national level hotspot analysis. And so the 3 dots there, that is Lusaka, Chipata, and Ndola. Those were the ones that actually were identified as a national level international level hotspot analysis. So when you now look at the actual provincial hotspot analysis, is where you are now going to find the actual facilities or areas that these clients are coming from, and this is what will inform the facility in that catchment area on what interventions to actually put in. And we have seen that with our challenge is the young girls, and so in this instance we need to come up with interventions that will actually be suitable for our young girls and adolescents, looking at the age groups that that were identified, and also going to places or targeting interventions that will target places that these age groups will be found, and then you go in with your public health response. So we actually just shared a slide to show the facilities that were identified in the 3 dots that I showed. So that's for Lusaka, that dot you were seeing, it consists of 22 facilities. These are the facilities that had hotspots. And so Lusaka, we had 2 hotspots. That is one with 22 facilities and one with 18. Then for Ndola, we had 3 facilities. And for Chipata district, we had 4 facilities. So the way these hotspots are identified, and when you put in your public health response interventions, so you put in all your interventions, once you do your analysis again, it is if your interventions are effective, you will find that you start seeing a reduction until you will stop seeing these recent infections as common in your in that catchment area. So that is how the recency testing is used to inform our programming, as well as how it helps us to actually activate the public health response. So in summary, what we are saying, or what we want people to understand, is that recency testing is useful when you want to better understand the HIV/AIDS epidemic, and especially if you want to estimate the new infections in the different KPs, as well as geographical areas for proper interventions. Like I mentioned, we do not have a one-size-fits-all kind of intervention. Then recency testing also it can help find partners. And like I mentioned, yes, this is what you will find other countries are implementing. But for us as Zambia, let's remember that we have not combined it with any index testing to find the partners, because we are not giving back the results. So the facilities do not know who these people are. And then thirdly, recency testing in Zambia is in the national HIV testing algorithm. So I hope that we will stop getting the questions from the facilities. And when are we getting our recency results? When they send forth or when you visit. So I hope it is clear that these results, they do not go back. They are just used for surveillance. And I did show how that surveillance is used, that is in the hotspot analysis. But you will not use it to find the partners. For others, yes, other countries, you can use it. But for Zambia, we are just using it for surveillance. Chair, this is where I'm sure people will want to ask some questions. I know the panel of experts, they've been tackling the questions in the chat box. And I hope we will see a better uptake or better implementation of the recency program. Thank you very much.
Awesome. Thank you very much, Madam Judith. And yes, indeed, there have been some questions coming up in the chat box, and our very able experts in the likeness of Dr. Mwenya Mubanga has been up to the task tackling some of those questions. However, I'm going to give him a chance to actually echo some issues here. But before that, I would also like to ask, of course, this is me acknowledging I have noticed Dr. Mwenya Mubanga, but I would like to find out if Dr. Vlahakis or even Dr. Fwoloshi are on the call. Just a confirmation, please. Dr. Chitalu, Chanda, are you on the call? Okay. I asked because I saw his name on the list, and he's an ID specialist, so I thought maybe in the absence of Dr. Fwoloshi, he could still give us their angle from that, their expertise as well, being also a subject matter expert. Dr. Mubanga, before you come in, just get ready. I would like to ask the network if there are any burning issues. You can raise your hand and I'll allow you to speak before I let our experts speak. I know this is quite interesting and people have some burning issues. This is a platform for everyone. I think we understand the model of all teach and all learn. Kindly, you can raise your hand and you'll be allowed to speak, contribute, or otherwise ask a burning question or clarification point. Any hands? Any hands? Anything that's not clear? I know some things have been typed. Some things have been typed and some answers. Okay. Josephat Wembia, you are free to go. Please unmute yourself. You may go ahead.
Yeah, thank you so much, Chair. I typed the question. I'm not sure if it's been responded to. I wanted a clarification regarding the issue of consent on doing it. But I thought when doing the initial test, you get consent from the client. So I noticed in the algorithm that at the point of doing the rapid test again for recency testing, there was the issue of getting consent. Do you again get consent from the client to do the rapid recency test? Over.
All right, thank you. Please next try to speak a bit closer to the mic, but I did get your question. Others have posted that they could not hear you. But Madam Mzyece, the question is quite straightforward. Why are we getting consent for recency testing when it is on the algorithm? I know Dr. Mubanga a bit of itch to respond to that one, but I think the answer was not satisfactory for our participant. Kindly please come in. Do come in. Dr. Mubanga, I'll allow you first.
Good afternoon, everyone. So thank you so much for that question. I think in terms of permission, it is obtained at the point of obtaining permission for HIV testing. So when we get bloods for the baseline viral load, that's when we take the sample as well for recency. We don't request additional permission to get those tests done, although we do encourage that information is given to the patient about what all the bloods that are being taken are for. So I don't know if that clarifies the question or the answer. Thank you.
Yeah, so
Thank
maybe I
you,
can
Doc.
just to add or clarify, I don't know,
Yes,
maybe those right. So what we mean, remember, like you rightly said, that it is done at before the testing is done. So once you have your results, so at the point of you sending the blood, you need to counter check that the consent was given. If it wasn't, then it falls off. So that is why it is in the that is why it is mentioned there. We drop those off. So I hope that is with what Dr. Mwenya has said, and here what I've explained, that in the algorithm where we are looking at, where we are emphasizing on it, is before you even send your samples for the baseline viral load, did the patient consent to that? And mind you, we all need you will agree that when we started, we were piloting this, and now we are now talking of going to all the 10 provinces, meaning that it will be a fully fledged program. So when you are starting a program, there are certain things that you need to adhere to. You need to actually get things done, and the consent was one of those things. But with time, I think when we expand, you will see that we will remove some of these things that we had put in at a pilot phase. Thank you very much.
All right, thank you. So, Mr. Wembia, one more thing, I think maybe just to add on to that, I was just thinking, Madam Judith, you test someone positive for HIV today, and then they don't know when they got the infection. Maybe they just recently started seeing or having a relationship with someone, and maybe they might not want to know that they just got that infection from that person, or I don't know if I don't know if those aspects matter would matter. Certain people might consider that important to know how long they have had the virus. Maybe others might want to just keep it. Maybe I've been sick unwell. I've carried this virus for longer than 1 year, and maybe, for a long time, and they might not wish to know. I think ultimately, I think it's just good practice for people to want to decide if they wish that information to be taken about them. I don't know. Namonga, kindly unmute yourself and go ahead.
Good afternoon.
Good afternoon.
Sure. I'm actually calling you from the correctional facility. I'm following the program. I have a situation. like we have this inmate who we tested HIV positive upon entry as our policy. Then he tells us to say he had had the infection since 1970 and he has never been on treatment since then. So of course we had challenges convincing him to start medication and all that. But then I'm thinking, after hearing this meeting, I'm thinking, how then will we classify this person? Is it a recent infection or how? How would you do it? Because we have actually collected the samples for all those, but I'm just thinking to myself, what are we doing? Thank you.
Thank you very much for that very important input. Yes, so Madam, unfortunately, she will not be able to get that result from Madam Mzyece, as she has said that we are not sending these results, but she needs that to understand. She needs to understand. Dr. Mubanga, please come in.
My apologies. My network missed the question that was asked. Could she please repeat the question? I'm so sorry about that.
Yes. So she has she works from the correctional facility, and they have an inmate who, as part of their procedure during incarceration, just at the time of someone being incarcerated, they did the HIV somehow weird, says that he's been HIV positive since 1970s or something like that. So now is adamant to start treatment to say I've had this virus for all this time. So they collected a sample for recency testing, and she doesn't know how to deal with this situation. Madam Namonga, you still have something to clarify. Please go ahead. Go ahead. Dr. Mwanga, just hold on. Madam Namonga is the one who was asking the question. Maybe she can add some more.
No, actually, it's the odd hand, I think. It's the same
Oh,
question.
all right, all right. Okay, Dr. Mwanga, I hope you got it.
Thank you very much for the question. So I think what we would encourage then is enhanced counseling for this patient, and then maybe retesting and additional measures to ensure that the patient does start treatment. We don't send recency test results back on an individual level for two reasons. The first is that the test itself is not validated for individual use. It's more, we use it on a surveillance level, so on a much more broader population-based level, not for the individual. And then on the second thing is that even if we send back the test results to a facility and say that this person is newly infected, it doesn't change how the person gets treated. So what I would advise with that specific client is, I would say, more additional counseling and then more contact with the patient as opposed to just looking at the recency results. Thank you.
Okay, thank you very much, Dr. Mwanga. Madam Judy, would you like to add something, or we allow Edwin to speak?
I think we can allow Edwin to speak. Dr. Mwanga has adequately answered the question.
Thank you.
Good afternoon.
Mr. Samukonga.
Thank you very much.
Please,
Good afternoon.
Good afternoon, Mr. Samukonga.
When are you extending the test to the other provinces that were not included in the initial? Thank you. I mean, in terms of specific timeline.
All right, thank you. I'm going to ask also Enoch from Lukulu to please ask your question. I know that Mr. Samukonga's question has been raised in the chat box, but then we'll allow it to be answered together with Mr. Enoch from Lukulu district.
Okay, thank you very much. I'm a little bit confused or behind, so I wanted the network to help me. I thought I want the team to draw a line for me between baseline VL as well as compared to license testing in terms of reclassification of the client type. Are the districts that are doing this particular testing not stopping the baseline VL? Are they doing it alongside the other? If so, if not so, then how do we rule out the issue of silent transfers as well as the newly identified positives? Thank you.
Wow. Okay. That's quite a lot. Miss Fales Zulu, is Miss Fales on the call, Madam Judy? Otherwise, please go ahead and tackle the question. Madam Fales? Oh, that's a baby talking, Agnes. Okay, Madam Mzyece,
I think,
please.
yeah, I think Dr. Mwanga can tackle that. Mwenya?
Okay, so thanks for that. So in terms of rollout, we plan to start, there is a process in which the rollout has been done. So all of the provinces in which we are, or the districts, have been done in a given order. And so we are going to roll out next into the Northwestern province, but we will roll out across the rest of the remaining 3 provinces by the end of the year. So it is in plan, and we've already started doing some groundwork in order to ensure that this happens. For the next question on using baseline viral load. So the challenge with recency results is that they come back as aggregate data and not individual level data. So we cannot use them for determining silent transfer. We also cannot use them for looking at, so basically we can't use them for looking at silent transfers. We use them on a population-based level because they are aggregate. What we do instead is we look at the baseline viral load and reclassify patients based on that. At the moment, since this policy on baseline viral load is fairly new, what we are looking at is to see how we can enhance the implementation of recency in the areas where we're finding that there are a lot of silent transfers, so that we also don't waste the recency test kits. So I hope that answers the question.
All right. Dr. Mubanga, while you are still on the floor, I think the question that has been asked about how selection for the districts was done, as it were. I noticed from the slide that was presented by Madam Judith, we had numbers like for Chipat, I think Mongo, which was saying 40, was it 54 or something like that? And the period being talked about was from about 2022 to 2023. And I was looking at how that data could be generalizable and be useful for program implementation and policy direction. Could we generalize this data with so small sample sizes? Or is there something that we were looking at in determining, or it was just something to say, okay, let's just pick these districts? Or where are we looking at the HIV burden, or any kind of format? I don't know if I'm getting my question through, because what I'm trying to understand is ultimately we want to use this information for some policy direction of sorts. So was there anything to look at? And then even as the numbers, the next point of the question is, as the numbers come through, those numbers which are seemingly small, I haven't statistically analyzed them to say that they are too small for statistical interpretation or acceptance. But I just want a general view on your part. Thank you.
Thank you very much for that question. So I think you've asked a question in, like, it's several different parts. So the first part is how the districts were selected. In terms of selection, they're selected based on prevalence. So if we look at the Zambia data, all of the provinces or the districts represented had a fairly high prevalence of HIV. So that's the first thing that you look at. It's the prevalence of HIV in a given area, district, or province. And then we also look at the facilities that are included within the given districts that are selected. So on the first part, it's prevalence that determined it. We will roll out nationally, regardless of prevalence, into other districts. However, initially, this was the criteria that was used. And then in terms of the slide that was shown, so what happens is we receive data, and what we have is then we have to determine where the confirmed recents are. And so what you have in that slide is where, sorry, so let me go back a little bit. We know that testing is basically most of the people who go in either test because they are taking themselves to facilities or because the provider has initiated testing. So already we have what is called selection bias, because this test is not being done to everyone. If it was being done to everyone, regardless of whether they choose or not, this is with the HIV test to start with. If it was just being done widespread across the population, then these results would be much easier to generalize to the population across the country. We could look at certain features and say, if you're like this, this is what you have. But what we have is we have a selected group of people, for whatever reason, who will go in, receive a test, and then amongst those who test, we look at who is confirmed recent. And then we also look at who amongst those who was tested was negative in the population. So what we get that were being showed are what we call a recency proportion. On the other hand, for programmatic use, so this information is very important when we are looking at how we're going to intervene on a programmatic level, because then we use that recency proportion to calculate the hotspots that she showed. And then those hotspots, we have a public health response that's very targeted at the area. So some facilities here, there's some people here who've been in facilities where we have gone in, or in areas where we've conducted a public health response. And then we look at the HIV program in general in that given area. However, when it comes to program, it's slightly different. So if we're going to share these results on a programmatic level, what we look at are the confirmed recents versus the unsuppressed in a given area. We generally try to provide both results so that everybody isn't left confused by looking at what look like really small percentages. If you look at the same results that Madam Mzyece presented, not on the recency level, but looking at them with the denominator of unsuppressed, you actually find that they look a lot more like what we're seeing on program level. So like the 9% for certain provinces or the 5% HIV infection. So that's the difference. But what we use with these results at the end is that we conduct a public health response, look at the program in areas where they're higher than normal number of new infections, and then we try and intervene at that level. So the end game is actually to conduct a response that will reduce HIV infection or transmission in a given area with a higher than normal number of infections. So thank you. I hope this clarifies it. Thank you.
It's brilliant. Thank you very much. Madam Judy, anything? Okay, so I just wanted to ask, maybe to come from Madam Judy or yourself, Dr. Mubanga. Just, I understand, and I wish to remind the platform, the network, that our strategies indeed in the HIV program have to either change, or should we say diversify, and check what to focus on. With our 95, 95, 95 being on course, as we are nearly there, or we are drawing close to there, our interventions and our programmatic approach in the HIV has to kind of evolve as well. We have to check our priority areas. And I think this is what we are doing with this recency testing. And indeed, as you have well elaborated, Dr. Mwenya, what you are actually intending to achieve with this. I wish to remind our platform that the reasons for checking the recency for the clients, they are quite a lot. And we are, as far as we have started implementing in the Zambian space, we may not be targeting all the positives or the intended reasons for doing recency, but we may be getting some reasons, addressing some, as Dr. Mwenya has alluded to. I just wanted to know, Dr. Mwenya and Madam Judy, either in the Southern Africa region, whoever, or East African region, or in the SADC region, if there are any countries which had started implementing recency testing before us, and if there are real-time examples of what they have established and what they have been able to change in terms of our intervention and what that has translated to. Do we have anything, any data on the ground, or are we kind of among the pioneers for this program? Kindly, thank you.
Wow, that is such a loaded question. So recency is being implemented in several countries within Africa, but also in Southeast Asia. And it's also used amongst key populations in the States and in some countries in Europe. So it's not that it's not being done everywhere. We've had questions about it being an experiment in this part of the world, but actually it's being conducted in several countries. I think something that Zambia has done very well is been able to use the results in a public health response, and also been able to integrate it into the national surveillance program. I think in addition, something that Zambia has done that we are more of a pioneer around is also that we have been able to use baseline viral load. Not all the countries use baseline viral load in their algorithm, but I think something else that's very key, and I think Dr. Vlahakis is online, I'll let her answer, is that we've been able to use recency quite well, I think in a bit more of a pioneering way. So if Dr. Vlahakis is online, could please unmute.
Thank you very much for a great presentation. I think it highlights some key issues around recency testing and the way we use it. So basically, I would say in many ways, you know, the public health response as stipulated in the national SOP, we have 6 steps in the public health response. And I think we've pioneered that here in Zambia. With the first responses held last year, one in Livingston and one on the Copperbelt. And I must say, you know, for the response that was held in Livingston, certain key things were put in place. So more or less precision public health. So, you know, there's an assessment that's done, you go onto the ground, you identify some key gaps in the program, following which interventions are put in place with site level staff. So with the facility and the district really taking the ownership and the leadership of that plan. And what then has happened beyond that, a year later, is that Livingston is no longer popping up as a hotspot. as it was before. So we're still, looking at that data critically to make sure that there, isn't anything else that we have missed. But clearly some key changes like bringing DREAMS programs into some of the communities, setting up more safe spaces in the communities, increasing awareness around HIV in the community, and providing prevention options in a bigger way than was being done at that time has really influenced the way the program is running there and led to some of these changes that we see now. Over to you. Thank you.
Thank you very much, and very wonderful to get those insights. It's happening, it's here. Madam Judy, we are at the end of our allocated time, and I wish to appreciate that the objectives for this session hopefully have been met, looking at, and I know everything has been tackled, both in the presentation and even in the responses given. If I were to go through them, define recency testing and the recent infection testing algorithm. Rita, this has been well done. The second one, describe the third test in the HIV testing algorithm. This has also been well tackled and really described. Use recency data to inform prevention intervention programming. Also, this has been well even deliberated upon. Madam Judy, Dr. Mubanga, Dr. Vlahakis, I appreciate that quite a number of questions that have been raised in the chat box have been attended to. However, I do wish and to ask for any take-home points, key issues that you may wish to give us. Over to you.
Thank you so much. I think, for me, one of the key take-home messages is, summary of what's been discussed today. So we do not look at recency data on an individual level. We analyze it for a group, a population. And the interventions that we put in place are targeted at the group of individuals or that community. Essentially, transmission happens in the community. So once changes are made at that level, it makes it more impactful. So by the national, what we have nationally as a protocol for recency surveillance, we do not trace the individual, but rather we look at the population around the surrounding facility that has been triggered as a hotspot, and then place interventions at that facility to be able to change the transmission, or rather to curb the transmission cycle ongoing. Thank you.
Thank you, Madam Judy.
Thank you very much. So just in addition to what Dr. Natalie has mentioned, for me, the take home to the team on the platform is that just like we have seen that recency testing is part of our national HIV testing algorithm. This means that it is a Ministry of Health program. So we expect that it should be given all the attention that it deserves, because in some places we've seen where people think it's just a study or some research, or it's a partner program, but this is a Ministry of Health program. That is why it is part of our national algorithm. Thank you very much.
Thank you very much. And to our coordinating team led by Madam Akufuna, Mercy Etambuyo, and also our IT team, Mr. Chatondamvula. I have been your host, our facilitator for today's presentation. I'm Dr. Mshanga Bhekilizwe from Northern Province in internal medicine at Mbala General Hospital. And it has been a pleasure to spend this an hour and a half with you. Have a great day and thank you.